Hello everybody. Today we are going to discuss the question which was asked in DRNB critical care exam, that is rhinocerebral mucormycosis. This question was asked in April 2024. Now first we'll start with the risk factor for the mucormycosis. Risk factor for mucormycosis is diabetes mellitus, hematological malignancy with neutropenia, organ transplantation, prior recipient of voriconazole, malnutrition, peritoneal dialysis, trauma including surgery, burns, iron overload, human immunodeficiency virus, immunosuppressive therapy, autoimmune disease. The clinical features of the mucormycosis is it could be disseminated, it could be rhinoorbital cerebral mucormycosis, there can be the gastrointestinal symptom, cutaneous soft tissue symptom, the pulmonary symptoms. Then rhinoorbital cerebral mucormycosis. Mucormycosis in the fungal infection that can spread from the sinuses to the oral mucosa, palate, brain, bone, and the orbit. Rhinoorbital cerebral mucormycosis is the name given to this condition. So, patients with the poorly treated diabetes mellitus are more likely to develop rhinoorbital cerebral mucormycosis. But it can also happen in the solid organ transplant recipient and the other immunocompromised host. In patients with the poorly regulated diabetes, dental procedure can be the risk factor for this type of mucormycosis. Dental infection can lead to the destructive infection of mandible and maxilla. Headache, fever, nasal inflammation, facial pain, palatine mucosa, eschar, dark nasal, and periorbital swelling are some of the signs and symptoms of this problem. Cellulitis, chemosis, proptosis, blurred vision are all signs of the orbital invasion. Intracranial progression through the direct extension or angioinvasion can happen quickly. The high mortality rate is linked to the brain involvement. Rhizopus oryzae are found to be responsible for 85% of rhinoorbital cerebral mucormycosis in a French analysis compared to just 17% of non-rhinocerebral mucormycosis. Now about pulmonary involvement. Involvement of the lungs, periregional ground glass opacities, centrilobar nodules, reverse halo sign, air crescent sign, lobar consolidation or peribronchial, upper lobe predominance, pleural effusion, bronchopleural fistula are the affected location through the invasion of active environment. Necrotizing pneumonia may occur when pulmonary vessels are invaded. Aspergillus causes the offensive ulcerative tracheobronchitis at lung transplant and a stomatic site recipient, but Rhizopus tracheobronchitis has also been reported. Now about cutaneous involvement. Involvement of the cutaneous mucormycosis can manifest as localized or disseminated disease in immunocompromised individuals. Traumatic injury, surgery, fires, natural hazard, war, and the insect animal bite and also the inoculation of the infected soil, trees, grasses, thorn, and water can cause cutaneous mucormycosis in the immunocompetent host. Mucormycosis in the fungal infection that spread quickly across the subcutaneous tissue, skin, bone, and the fascia. Now about gastrointestinal tract involvement. The introduction of the gastrointestinal tract by 2 to 11% of patients with mucormycosis develop gastrointestinal involvement which is fatal. In study of 31 cases of gastrointestinal mucormycosis, 42% involves the stomach and 52% of cases included intestine. Hepatic presence is quite uncommon in the present scenario. However, as per suggestion, hospital therapy and surgical resection combined with the aggressive surgery can be curative in this case. Now about clinical diagnosis, high index of suspicion, identification of the host condition, rapid evaluation of the clinical symptoms are all needed for the diagnosis of mucormycosis. Diplopia in the diabetic patient and the pleuritic pain in the neutropenic patient may be the sign of infection, prompting the use of imaging technique and the eventual collection of specimen for histology, microbiology, and advanced molecular research. As stated earlier, rhinocerebral pulmonary soft tissue and disseminated infection are most frequent clinical manifestations of the mucorrheic infectious disease. Mucormycosis is characterized by the tissue necrosis. However, the appearance and the syndrome-based method of diagnosis lack the sensitivity and accuracy. Other fungus such as Aspergillus fusarium may cause similar complications. History of previous voriconazole prophylaxis or the occurrence of breakthrough fungal infection in immunocompromised patient receiving antifungal agent functional against Aspergillus. Cranial nerve palsy, sinus pain, diplopia, periorbital swelling, proptosis, and palate ulcer, orbital peak syndrome are among the signs and symptoms that can be called as red flags. Mucormycosis is said to be associated with the numerous nodules and the pleural effusion on the radiography. Reverse halo symbol is the another CT scan finding that seems to suggest existence of the mucormycosis. Now, the reverse halo sign is seen in 15 out of 16 patients within week of disease in new review of consecutive thoracic CT scan of leukemic patient with neutropenia. Other radiological observations like numerous nodules which appear later. The investigation suggests that appearance of the reverse halo sign on CT was a good indication of pulmonary mucormycosis in neutropenic and leukemic patients with pulmonary infection. The reverse halo sign was more prevalent in mucormycosis patient than in Aspergillus patient. While certain airway invasive characteristics such as cluster of central lobular nodule, bronchial wall thickening, peribronchial consolidation are more frequent in Aspergillus patient. Then the PET scan is yet another imaging strategy that may ultimately help in management and the diagnosis of mucormycosis. Endobronchial ultrasound guided fine needle aspiration is indeed helpful screening technique. About culture and microscopic examination. Direct and histopathology microscopy and different clinical culture specimen are diagnosing mucormycosis cornerstone. Mucorale hyphae have a variable diameter and are non-septate or pauci-septate and have an irregular and ribbon-like structure. Branching angle varies with the wide angle bifurcation being common. On hematoxylin and eosin parts, the fungal elements are easily visible. Gomori silver staining is often used to illuminate fungal hyphae, allowing for more detailed analysis of anatomy. Inflammation, whether neutrophilic or granulomatous, dominate tissue histopathological result in few cases. Inflammation appear to be absent, especially in immunocompromised patients. The presence of prominent infarct and angioinvasion characterizes the invasive disease. Perineural invasion can be present when nerve structures are involved. As compared to non-neutropenic patients, neutropenic patients have a more severe angioinvasion. Histopathological examination of the tissue sample is not always capable of distinguishing mucorale hyphae with aspergillus or morphological characteristic related to the fungus. Tissue identification, on the other hand, is an important diagnostic tool because it distinguishes between the existence of fungus as a pathogen in tissue and the presence of culture contaminant. Mucorale grew quickly on the most fungal culture media like potato dextrose, and the subrod agar incubated at 25 to 30 degrees Celsius. A microaerophilic condition increases culture yield for sustained variety. Surprisingly, even though fungal hyphae are visible in the histopathological examination, 50% of fungal cultures are positive. Since hyphae are brittle, they could be harmed as a result of tissue manipulation. Now, antifungal susceptibility testing and species identification. Characterization of the organism is the critical for having deeper epidemiological knowledge of mucormycosis and could aid epidemic investigation. Mucorale fungus are easily distinguishable from the Aspergillus fungus when grown in the culture. When assessed by individual with the expertise in fungal detection, Alvarez et al. Found that morphological characteristic alone could provide high accuracy. However, morphological specimen classification is challenging and may be due to speciation failure. ID32 kit and API 50CH have been successfully used for recognition of R, R. Pusillus and the Lycanthemi acrombifera as well as mucor species. Both tests fail to differentiate uh, M. circinelloides and M. raixu or L. ramosa is detected using ID32 and positive melazitose assimilation. MALDI-TOF mass spectrometry is the promising instrument, but it has not been validated for the mucor. M. circinelloid has high MIC for posaconazole as well as Cunninghamella and Rhizopus for amphotericin B. So MIC against amphotericin B also increased in certain apophysomyces isolate. The role of such a data in patient care is uncertain, requiring further investigation. Now about serology, a reasonable test such as enzyme-linked immunosorbent assay, immunoblot, and the immunodiffusion were evaluated based on degree of their effectiveness. The three hematological patients who developed invasive mucormycosis and enzyme-linked immunospot assay have been used to identify mucorel-specific T cell. Additionally, mucorel-specific T cells were used in infected patients to recover over the disease. Although there will be further studies towards the use of this special T cell as a surrogate diagnostic marker. Now about molecular assay. Conventional PCR, RFLP, and the DNA sequencing of identified gene region and the melt curve analysis of PCR product are all examples of molecular based assay. Many of these assay mentioned above can be used to detect and identify mucus. The internal transcript spacer or 18S RNA gene are the focus of majority of molecular assays. Several studies have been conducted using paraffin embedded or a fresh tissue sample, formalin fixed with varying results. The study performed for sensitivity and specificity showed varied results, but lower number of patients examined being the critical shortcoming. Since efficacy of this in-house assay has not been extensively tested and clinically evaluated, they cannot be put forward as a single stand alone in the clinical routine diagnostic. This approach is used. Molecular diagnosis from the blood and the serum has yielded positive clinical result in 39% of cases. With opposed to culture, early diagnosis and overall confirmed culture proven cases were achieved using molecular based diagnosis from serum. At this point, molecular based diagnostic assay may put forward as a useful supplement to traditional diagnostic procedure. Now, advancement in the diagnosis. Histopathology and the cultures are used to diagnose mucormycosis. Mucorales are prone to vascular invasion and tissue damage in the organ they infect. Tissue infarction occur when the blood vessel become thrombosed. Consequently, a plaque eschar may form. Gram stain is ineffective on the mucorale. Mucorale have a long, non-septate ribbon-like hyphae with the branches at the right angle in tissue specimen. Mucormycotic infection may cause neutrophilic granulomatous or non-specific inflammatory changes, as well as angioinvasion or infarct in some cases. Fine needle aspiration biopsy may be used to confirm diagnosis when focal pulmonary nodule or masses are present. Even if histopathology reveals characteristic organism, culture can be negative. Grinding tissue specimen for culture also result in hyphae damage due to scarcity of septation, which prevent growth in the culture. In mucormycosis, serological tests for D-glucan and Aspergillus galactomannan are negative. For certain organisms, for example, Rhizopus, Mucor, Rhizomucor, and the Lichenthemia, quantitative PCR in serum or tissue is available and may be superior to the culture. Matrix assisted laser desorption or ionization time of flight tend to be another tool with high precision for separating mold from the culture. Next generation sequencing can detect IMI in uh, blood sample, which could lead to earlier detection of this infection. Now about therapy. Mucormycosis is uncommon phenomenon causing the deadliest opportunity in affected patients. However, liposomal amphotericin B can be employed as a first-line treatment to cure the mucormycosis disease. Triazole and the mucorale activity are approved by the FDA to treat adult mucormycosis, while POSA having mucorale activity was used as salvage and induction therapy. Subsequently, surgical debridement served as essential supporting role, especially when there is a participation of soft tissue or rhinocerebral. The importance of reversing underlying risk factors such as glucocorticosteroid discontinuation or taper, neutropenia resolution, deferoxamine discontinuation, diabetes regulation, and immunosuppressant reduction cannot be overstated. Many antifungals are immune to the mucor. The most active agent include liposomal amphotericin B and the newer triazole like posaconazole and isoconazole. On the other hand, echinocandin and voriconazole have deficient activity against the mucorales. Mucormycosis have been treated with liposomal amphotericin B for the long time. Isoconazole and posaconazole have the primarily been used as salvage therapy in patients who have been developed resistance to and intolerance to liposomal amphotericin B. For mucormycosis, high-dose lymphosomal amphotericin B for minimum of 6 to 8 weeks is assumed to be the first-line therapy. Now about combination therapy. Combination therapy was not used to be superior to monotherapy in retrospective review of patient with mucormycosis complicating healing. The effectiveness of combined antifungal therapy for mucormycosis is unknown due to risk of evidence. Hence, there is need of experimental setup for observing alteration in the given therapy. About surgical therapy, resection of surgical debridement plays a vital role in the adjunctive treatment in the mucormycosis patient. Surgery and liposomal amphotericin B, uh, this were both linked to the improved survival. Consequently, soft tissue injury, rhinocerebral mucormycosis, and cases of pulmonary disease were seen to be effectively diagnosed by surgical therapy. Now, ion chelator, deferoxerox is the kind of ion chelating agent that increases longevity in the mice with the diabetic ketoacidosis. It is very effective in patient against the liposomal amphotericin B treatment. So it is successful. It was successful in one patient with rhinoorbital cerebral mucormycosis. Now about salvage therapy. Salvage therapy is provided when the patient does not respond to normal first-line therapy with amphotericin B. The assessment of the antifungal medication failure necessitated the caution. Patients with mucormycosis frequently have coexistent fungal and the bacterial infection, as well as non-infectious diseases such as leukemic infiltration, medication toxicity, or organ failure, which can make measuring therapy response difficult. Furthermore, an initial paradoxical deterioration reported in cancer patient with pulmonary mycosis in context of neutrophil recovery could be misinterpreted as a treatment failure. Switching to different class of antifungal agent is the general principle of salvage therapy. However, mucorale is the only susceptible to the two types of antifungal drug. In this case, options are to increase LAM dose or to switch to posaconazole or isoconazole. Now, role of antifungal prophylaxis. It is still under investigation whether antimucorale antifungal should be used for primary and secondary prophylaxis in high-risk individuals. Presently, posaconazole is strongly suggested as a prophylactic to prevent invasive fungal infection, in patients suffering from the severe neutropenia. Now this is the summary of the antifungal used to treat mucormycosis. So first is this posaconazole. Posaconazole we can use in the IV or tablet form, that is 300 mg from a day, from the day 2, and that is 2 into 300 mg on day 1. Oral, if we are planning to use in the oral form, then around 2 into 400 mg per day, that is 800 mg per day, or 4 into 200 mg per day. Amphotericin B, if there is a CNS participation, then 1 mg per 100 gram per day of lamb, and no CNS participation, then 0.5 mg per 100 gram per day of lamb. And the total duration of therapy is 6 to 12 weeks. The combination therapy can be given in the form of isoconazole, posaconazole, and lamb plus echinocandin. Then, if you are planning to use isoconazole, then it should be used in the dose of 3 into 200 mg on day 1, that is 600 mg on day 1, and 1 into 200 mg per day from day 3. So, total duration of this therapy is 3 months. So, for the patient group, fever driven or empirical, which is unresponsive to antibiotic, febrile neutropenia, imaging reverse halo sign, galactomannan negative, and other typical presentation in multiple nodules. So we can treat this patient with a liposomal amphotericin B. As a prophylaxis, can be given in the patient with graft versus host disease or prolonged neutropenia, solid organ transplantation, prolonged neutropenic patient, heart and the lung transplant, immunocompromised due to previous mucormycosis diagnosis. So this patient we can treat with the posaconazole, either intravenous or tablet, that is 600 mg on day 1 and 300 mg from day 2. Then isoconazole in the intravenous or oral form, that is 600 mg on first 2 days, then 200 mg per day from day 3, and 200 mg per day from day 1. In same patient, surgical resection and the last medicine effective as a secondary prophylaxis, switch from amphotericin B to posaconazole after 3 to 6 weeks, if practicable. Then, as a salvage therapy, can be tried in the refractory disease and toxicity to the primary therapy. So, this we can treat it with the help of isoconazole in either intravenous or oral form, that is 2 into 3 into 200 mg, that is 600 mg for first 1 to 2 days, then 200 mg from day 3, then posaconazole either in the form of a tablet or the IV form, that is 600 mg on day 1, 300 mg from day 2, amphotericin B in the lipid formulation, 5 to 10 mg per kg. Then mucormycosis, the treatment line is, first we need to reverse the underlying cause. That means we need to control the sugar, taper steroid, and withhold immunosuppression. Primary therapy we can give in the form of isoconazole, posaconazole, and amphotericin B for 3 weeks. If it is ineffective, then we can give the combination therapy. Adjunctive therapy we can give in the form of ion chelator, hyperbaric oxygen, interferon, granulocyte colony stimulating factor, and soda bicarbonate. Then we can also go for the surgical reconstruction therapy, like in the form of debridement, extensive or tapered resection, and salvage therapy. If you are planning to give, then we should give in the form of isoconazole, posaconazole, or Rizan amphotericin B for 10 mg per kg dose. Thank you, guys.